Welcome to a brand new deep dive. We are so glad you are joining us today because we're looking at something that is, well, it's deeply personal and honestly really often stigmatized.
Oh, absolutely. It's one of those things society just kind of expects to happen effortlessly, like
Yeah.
this automatic biological
Right,
sequence.
the whole nursery rhyme picture, we're all fed. But today, we are taking you into the actual gritty mechanics of human reproduction. Our source material for this deep dive is this incredibly comprehensive clinical textbook chapter.
Yeah, it breaks down the causes, the care management, and just the mind-blowing reproductive technologies associated with infertility.
It really is mind-blowing, and our mission today is to take this really dense medical text and, well, map it up for you. We want to transform it from this scary clinical thing into a fascinating look at human biology, emotional resilience, and some seriously cutting-edge science.
Because when you actually look at the clinical data, that whole societal narrative of easy reproduction, it completely falls apart. I mean, the Centers for Disease Control and Prevention, the CDC, they track these statistics, and they are pretty jarring.
Yeah, I was shocked by the numbers.
Right. It's about 19% of people aged 15 to 49 who have no prior births who experience infertility. And clinically, just to define that, that's the inability to conceive after 1 year of unprotected intercourse.
Or 6 months if the individual is over 35. Yeah.
Exactly. 6 months if you're over 35.
The 19%. That is almost 1 in 5 people.
Yep.
And that only covers getting pregnant. Because the
Yeah.
data also tracks this other metric, which is called impaired fecundity, which is just a very clinical way of saying the physiological inability to carry a pregnancy to term.
And that number is even higher.
It is. It affects 26% of the same group. So we are talking about a massive portion of the population dealing with either the inability to conceive or just the profound heartbreak of recurrent pregnancy loss.
Okay, let's unpack this. Because to understand why those numbers are so high, we have to look at the actual biological roadblocks.
And the very first thing the clinical data does here is shatter a massive historical misconception. For centuries, literally centuries, the burden of infertility was placed almost entirely on the female partner.
Oh, yeah. Completely blamed on women.
But modern medical diagnostics reveal a completely different breakdown. It's a 40-40-20 split.
Right. So 40% of infertility is related to a male factor or a combined male and female factor.
Mm.
Another 40% is strictly a female factor.
Mm.
And then, and this is the part that always gets me, that remaining 20%, it's entirely unexplained.
Wait, entirely? Like they just don't know?
Exactly. Even with advanced imaging, hormonal mapping, genetic screening, all the tech we have, 1/5 of the time, medical science simply cannot find a definitive biological reason why a pregnancy isn't happening.
Wow, that has to be so incredibly frustrating for those patients.
Unbelievably frustrating.
Well, let's break down the biological hurdles we do know about, maybe starting with the female side of that 40-40-20 split. The diagnostics usually start with hormonal and ovulatory factors, right?
Yeah. And the most common one there is an ovulation, which is just a complete lack of ovulation. The ovaries are simply not releasing an egg.
And what causes that?
It can be driven by a bunch of systemic issues. You have things like polycystic ovarian syndrome or PCOS, which really disrupts the normal hormonal feedback loop.
Mhm.
Obesity can actually cause an ovulation too, because it increases peripheral estrogen production.
Okay, so too much estrogen messes up the signal.
Right. And conversely, you have functional hypothalamic amenorrhea.
That is a mouthful.
It really is. Basically, it's chronic anovulation triggered by extreme weight loss, intense psychological stress, or really strenuous athletic training. The brain essentially thinks the body is in starvation mode.
Like a high-stress survival state.
Exactly. So it just shuts down reproduction entirely to conserve energy.
Wow. So beyond whether an egg is actually released, there's also the question of the egg supply itself, right? The text talks about diminished ovarian reserve or DOR.
Yeah, DOR. That's the natural age-related decline in both the total number and the genetic quality of the ovarian follicles. The data flags this as the primary driver behind age-associated infertility.
Okay, so that's the hormonal side. But then you have structural issues, like tubal and pelvic factors.
Right, the fallopian tubes. They are delicate, incredibly narrow pathways, and they are highly susceptible to inflammatory damage. Endometriosis is a huge culprit here.
Endometriosis, that's where tissue similar to the uterine lining grows outside the uterus, right? Like on the ovaries or the bowel.
Yeah, exactly. And the mechanism behind why that causes infertility is it's brutal. That displaced tissue still responds to monthly hormonal cycles, so it thickens, breaks down, and bleeds.
Oh, wow.
But because that blood is trapped inside the pelvic cavity, it creates severe inflammation, and that inflammation turns into sticky scar tissue or adhesions.
Which can basically glue the fallopian tubes shut.
Yep. Or warp their shape so they can't physically reach out and pick up an egg when it's released.
Ouch. The text also mentions something called a hydrosalpinx. What is that?
Oh, that's another severe structural roadblock. If a fallopian tube is damaged or blocked at the far end, it can fill up with fluid. But the cells lining the tube, they keep secreting fluids, which then have nowhere to go but backward.
Backward into the uterus.
Exactly. It drains directly into the uterus. And that inflammatory fluid is actually chemically hostile. It's essentially toxic to a developing embryo, so it prevents implantation even if fertilization somehow happens.
That is terrifying. Okay, flipping over to the male factors, that other 40%. The issues there almost always come down to either the factory production or the swimming ability of the sperm.
Right. You have azoospermia, which is a complete absence of sperm in the ejaculate, and oligospermia, which is a significantly low sperm count.
And the text highlighted some really surprising environmental and lifestyle factors for this. I mean, it really highlights how sensitive the male reproductive system is.
Oh, incredibly sensitive. Spermatogenesis, the creation of sperm, requires an environment about 2 degrees Celsius cooler than core body temperature. That is the anatomical reason the testes are located outside the body.
So if things get too warm.
The factory literally shuts down. If the scrotum is routinely exposed to high temperatures, through daily hot baths, extremely tight athletic clothing, or even prolonged laptop use on your lap,
Wait, really? A laptop can cause infertility.
it can definitely disrupt sperm development by overheating the area. And it's not just outside heat. Internal anatomy can cause overheating too, like a varicocele.
Right, the text described that as a cluster of dilated varicose veins inside the scrotum. It acts like a broken radiator, just pooling warm blood around the testicles.
Exactly.
Yeah.
And beyond temperature, there are chemical and viral disruptors. Marijuana use is heavily documented in the clinical data as having a direct link to poor sperm morphology and motility.
So it affects their shape and how well they swim.
Yeah. And the viral disruptors are really fascinating chronologically speaking, like contracting the mumps virus during childhood.
The mumps. How does that work decades later?
It's purely mechanical. The testicles are encased in this tough, unyielding fibrous capsule. So when the mumps virus causes massive inflammation, the swelling has nowhere to expand outward.
Oh no, so the pressure builds inward.
Exactly. It
Okay.
literally crushes the delicate, tightly packed seminiferous tubules where the sperm are manufactured, and it causes irreversible scarring.
That is so intense. Looking at all these physical traps, the inflammatory responses, the temperature sensitivities, I was thinking about it, and it really feels like human reproduction is a high-stakes relay race.
A relay race. I like that.
Yeah, like the gametes, the sperm and the ova, they all the baton. And the ova only remain viable for about 24 hours. The sperm only retain fertilization potential for a bit longer.
Right. The window is tiny.
So if there is a single hurdle on the track, like cervical scar tissue, a varicocele, or a hormone imbalance, the baton drops. The race is over.
What's fascinating here is exactly why this whole system is so easily disrupted. Because governing this entire relay race is the hypothalamic pituitary gonadal axis.
The HPG axis.
Right. It's this intricate communication highway between the brain and the reproductive organs. The hypothalamus in the brain releases hormones that tell the pituitary gland to release secondary hormones.
And those travel through the bloodstream down to the ovaries or the testes.
Exactly, to stimulate gamete production. And normal, intact functioning of this axis is an absolute prerequisite for fertility. If psychological stress, extreme exercise, or an endocrine-disrupting chemical interrupts just one microscopic signal on that highway, the whole physiological sequence just collapses.
Which naturally brings us to the next phase of this deep dive. When the system does collapse, how do doctors figure out where the invisible roadblock actually is?
They basically have to start playing detective.
And there's a cardinal rule here in the diagnostic guidelines. Both partners must be tested simultaneously.
That is so crucial. You cannot test one individual for 6 months, find nothing, and only then start investigating the other.
Because the biological clock is actively ticking down that ovarian reserve, so it has to be a parallel track to avoid wasting time.
Exactly. For the female partner, the diagnostic toolkit relies heavily on mapping out that endocrine system and visualizing the anatomical structures, like the AMH blood test.
Right, anti-Mullerian hormone.
Yes. Because AMH levels remain relatively stable throughout the menstrual cycle, they can draw that blood on any day. It provides this really crucial quantitative measurement of the remaining ovarian reserve.
But blood work only tells you about the hormonal signals. You need imaging to actually see the physical obstacle course, right?
Yeah, you have to see the track.
And one of the primary imaging tests is the HSG, or hysterosalpingogram. And honestly, the mechanics of this test sound intense.
They are. Doctors thread a catheter through the cervix and actively flush a radiopaque contrast dye up into the uterus and out through the fallopian tubes. Then they take real-time x-rays to watch how the dye flows, looking for blockages.
But pushing fluid into a closed uterine space, that has to cause significant cramping.
It causes a lot of cramping. The clinical guidelines actually explicitly advise medical teams to provide anti-anxiety interventions beforehand.
Like music therapy or guided breathing,
Yeah,
right?
because the sheer anticipation of this invasive test causes massive psychological stress, which actively heightens the central nervous system's perception of pain.
That makes total sense. It's an incredibly vulnerable procedure.
And if the HSG or standard ultrasounds are inconclusive, the next step is often surgical, laparoscopy.
This is where they pump carbon dioxide gas directly into the abdominal cavity, right?
Right. The gas acts like a balloon, lifting the abdominal wall up and away from the internal organs to create a hollow workspace. Then they insert a lighted endoscope through the belly button to directly visualize the outside of the uterus, the ovaries, and the fallopian tubes.
Which is the gold standard for diagnosing mild endometriosis, since that's so hard to see on a standard ultrasound.
Exactly.
Meanwhile, the detective work for the male partner typically begins with a much less invasive step, just a basic semen analysis.
Yeah, though it does require a specific window of 2 to 5 days of abstinence beforehand. They analyze the sample for total sperm count, morphology, which is the shape and structural integrity, and motility, which is how well they swim forward.
And the diagnostic journey doesn't stop there. The tech spends a lot of time on inclusive care, specifically transgender fertility issues.
Yes, our medical sources devote significant focus to this. Standard clinical practice dictates that all transgender clients must be counseled on fertility preservation options before or during their medical transition.
Because the biological options depend entirely on the individual's pubertal status, right? Like where they are in their hormonal therapies.
Exactly. For transgender women who have gone through endogenous puberty but haven't started estrogen therapy yet, freezing sperm or testicular tissue are standard options.
And transgender men have the option to undergo egg retrieval to freeze oocytes, freeze embryos, or cryopreserve ovarian tissue.
Right. But this specific area of care requires profound empathy from the medical team. Because if an individual has already begun gender-affirming hormone therapy, they usually have to temporarily discontinue those hormones.
To allow the reproductive axis to wake up and produce viable gametes?
Yes. But pausing those hormones, allowing testosterone or estrogen to flood back into a body that finally feels aligned, they can trigger intense, debilitating gender dysphoria. It is an immense psychological burden to ask someone to pause their gender affirmation just for the chance of preserving their biological fertility.
It really is. Now, I want to circle back to a specific male diagnostic factor that really stood out in the clinical data. Wait, the text mentions men with congenital bilateral absence of the vas deferens, CBAVD, which is heavily linked to cystic fibrosis mutations. If there's no vas deferens to transport the sperm, does that automatically mean they can't have biological children?
This raises an important question. It beautifully highlights the difference between an anatomical roadblock and a production failure. You would assume the absence of the vas deferens means the definitive end of the line.
Right, because there's no way out.
But men with this specific obstructive condition actually continue to have perfectly normal, robust sperm production deep inside the testicle.
Okay, so the factory is operating at full capacity, but the delivery trucks literally have no road to drive on.
That is exactly it. Because the internal spermatogenesis is uninterrupted, these individuals are prime candidates for surgical sperm retrieval. A urologist can perform a minor procedure to extract the microscopic sperm directly from the epididymis or the testicular tissue itself.
Wow.
And with advanced laboratory techniques, those retrieved sperm can absolutely be used to create biological children.
Which brings us to the psychological reality of this entire process, because finding the anatomical roadblock or the hormonal misfire, that's often just the beginning.
Oh, absolutely.
Now the patients actually have to survive the treatment plan, and the clinical literature pulls no punches here. The psychosocial toll of an infertility diagnosis is categorized as a major life stressor.
It really is. It triggers a profound documented grieving process. You see cycles of denial, anger, deep-seated guilt, depression, and just severe social isolation.
It permeates every single facet of an individual's life. It fractures self-esteem, it strains relationships, and one of the most insidious side effects is how the intense medicalization of reproduction completely destroys physical intimacy.
Because suddenly, intercourse is no longer a spontaneous act of connection.
Right. It becomes this mandatory clinical chore dictated by basal body temperature charts, luteinizing hormone test strips, and a strict biological clock. It causes immense strain on a couple's dynamic.
Which is why the clinical guidelines treat preparatory and concurrent psychological counseling as essentially non-negotiable.
So how does modern medicine actually overcome this biological gauntlet? The therapies in the text range from basic lifestyle optimization to procedures that sound like science fiction.
Yeah, it always starts with the baseline. Optimizing body mass index, shifting toward nutrient-dense, plant-based diets, and entirely eliminating chemical disruptors like nicotine and marijuana.
But when lifestyle optimization isn't enough, you move to pharmacologic therapy, right? Like oral ovulogens, clomiphene citrate, or letrozole.
The biological mechanism behind these drugs is fascinating. Clomiphene essentially binds to estrogen receptors in the brain, blocking them. So the brain suddenly perceives a massive drop in estrogen, goes into a state of panic, and dramatically increases the output of follicle-stimulating hormone, or FSH.
And that sudden surge of FSH hyperstimulates the ovaries, forcing them to mature and release multiple eggs in a single cycle.
Exactly.
But when you're dealing with severely damaged fallopian tubes or profound male factor infertility, oral medications are useless. You have to bypass the internal anatomy entirely. Which brings us to assisted reproductive technology, or RT.
Right. The foundational procedure here is intrauterine insemination, or IUI. That's where a highly concentrated, biologically washed sample of sperm is injected directly through the cervix and into the uterus at the exact moment of ovulation.
So it literally cuts the physical distance the sperm have to travel in half.
Exactly. But the really revolutionary advancement is in vitro fertilization embryo transfer, or IVF-ET. IVF completely externalizes the most dangerous parts of the biological obstacle course.
The patient undergoes intense hormone injections to mature multiple eggs at once.
Then a surgeon uses an ultrasound-guided needle passing through the vaginal wall directly into the ovaries to aspirate the fluid and retrieve the eggs.
And those eggs are fertilized in a highly controlled laboratory incubator, monitored as they divide into embryos, and then carefully transferred back into the uterine cavity.
Right.
Here's where it gets really interesting. What happens when the sperm count is so incredibly low or their motility is so poor that can't even fertilize an egg in a laboratory dish?
Yeah, like the CBAVD patients we talked about earlier.
Exactly. Let's say you only have a handful of surgically retrieved sperm. Medicine developed a micromanipulation technique called intracytoplasmic sperm injection, or ICSI. The embryologist places the egg under a powerful microscope, takes an impossibly thin hollow glass needle, selects one single morphologically perfect sperm, and physically injects it directly into the center of the egg.
They're literally bypassing every single natural barrier of fertilization by hand.
Yes. Combine that with the assisted hatching we read about, where they use invisible infrared lasers to blast a microscopic hole in the embryo's outer shell to help it attach to the uterus. We are using microscopic engineering to force the creation of human life.
If we connect this to the bigger picture, this unprecedented level of microscopic control introduces some of the most complex ethical and legal dilemmas in modern medicine.
For sure.
We aren't just creating embryos in a lab anymore.
Yeah.
We have the technology to evaluate them before they ever reach a uterus. The clinical data heavily focuses on pre-implantation genetic testing, or PGT.
Right. Because an embryologist can use that microscopic laser to slice off 3 to 5 cells from the outer layer of a 5-day-old embryo. They extract the DNA from those cells and run a complete chromosomal analysis.
Exactly. They can identify abnormal numbers of chromosomes, which often lead to miscarriages or conditions like Down syndrome. Or they can even screen for specific devastating monogenic disorders like cystic fibrosis or Huntington's disease.
So this testing allows the medical team to consciously select an embryo that is genetically unaffected by these conditions.
But IVF is a numbers game, right? To ensure success, you stimulate the ovaries to produce as many eggs as possible, which often leads to the creation of surplus viable embryos.
And because transferring multiple embryos severely increases the risk of dangerous multiple pregnancies, the standard of care is to transfer one single embryo and cryopreserve the rest in vats of liquid nitrogen.
And those frozen embryos can remain biologically viable for a stunning amount of time. I mean, the medical data points to healthy live births resulting from embryos that were suspended in liquid nitrogen for over a decade.
Over 10 years, which creates a massive legal minefield.
Oh, huge. Couples undergoing IVF must sign legally binding directives outlining exactly what happens to those cryopreserved embryos in the event of death, divorce, or just if they decide their family is complete and they no longer wish to pay the yearly storage fees.
Right. Do you thaw and discard them? Do you donate them to another couple? Do you donate them to scientific research?
When couples divorce, who retains custody of a frozen cluster of genetic material? It is a space where the velocity of medical science has profoundly outpaced our legal frameworks.
It truly has. And as we map out the final stages of this clinical deep dive, it's crucial to acknowledge that while assisted reproductive technology is miraculous, it is not the only valid resolution to this journey.
No, absolutely not.
The biological hurdles are sometimes insurmountable, or the physical, financial, and emotional toll of the treatments simply becomes too heavy to carry. The source material outlines alternatives that pull us out of the sterile laboratory and back to the deeply human elements of choice, family, and acceptance.
Right. For individuals who physiologically cannot carry a pregnancy, the medical framework supports third-party reproduction. This includes utilizing a gestational carrier.
Which is someone who carries a pregnancy to term but has absolutely no genetic link to the fetus, right?
Exactly. The embryo was created using the intended parent's gametes, or donor gametes. And this is biologically and legally distinct from a traditional surrogate who actually donates her own egg and carries the child, making her genetically related to the baby.
And beyond any form of medical intervention, the clinical guidelines emphasize the incredibly beautiful path of adoption. The text actually prompts counseling teams to ask prospective parents a really vital, clarifying question.
Yeah, that question is so important, they ask. Is your primary goal to experience the biological act of pregnancy? Or is your primary goal to raise a child and become a parent?
Because hyper-focusing on a genetic link can sometimes obscure the alternative ways of building a deeply loving family.
And finally, the clinical framework explicitly validates the conscious, empowered decision to live without children.
Which is so important to mention.
It really is. For many individuals, after enduring the grueling physical injections, the invasive surgeries, the emotional devastation of failed cycles, finding peace and resolution in a child-free life is the healthiest possible outcome. It is a profound transition of life goals that deserves absolute respect and comprehensive psychological support.
So what does this all mean? Why spend an entire deep dive dissecting the clinical pathways of human reproduction for you? Well, because whether you are navigating your own complex family-building journey, trying to support a loved one who is quietly enduring this medical gauntlet, or simply fascinated by the extreme resilience of human biology, understanding these mechanics fundamentally shifts your worldview.
It really does. It replaces that casual societal judgment of, when are you having kids, with deep informed empathy.
Exactly. It replaces the agonizing isolation of an infertility diagnosis with a profound awe for just how miraculous it is when that biological obstacle course is actually conquered.
And as we look at the breathtaking speed of these medical advancements, it leaves us with a provocative question about the future. We detailed pre-implantation genetic testing and our rapidly expanding ability to select embryos free of certain chromosomal abnormalities or inherited diseases.
Right.
But as this microscopic control becomes more advanced and more accessible, how might our societal definition of a healthy human evolve over the next 50 years? As we gain the unprecedented power to consciously guide our own cellular destiny, we must ask who ultimately gets to decide which genetic traits are selected for and which are discarded. And what does that mean for the beautiful, unpredictable future of human diversity?
A profound thought to leave you with. Thank you for joining us as we explored the intricate science, the heavy emotional reality, and the awe-inspiring advancements behind human reproduction. We will see you on the next deep dive.